a meeting between Dr. Kotwal and I, and you can be part of it.
Sure, sir. Sure, sir.
And then discuss this whole thing.
Sure, sir. Definitely. Are we live?
Yes, sir. We are live now.
Hello, everyone. Greetings. Myself, Dr. Mohanty Shenoy. I work as a senior consultant endocrinologist in Trivandrum. I am also part of the ESI and ITS Executive Committee. And we are today having a conference, a virtual meeting, webinar, which is being hosted across the world. And it is on the occasion of World Thyroid Day, because it's the prelude to World Thyroid Day. Today, we are having a meeting as well as on tomorrow from 11 a.m. So this is a virtual opportunity to interact. Today's topic will be focused on the pediatric part of endocrine and pediatric thyroidology. And very grateful that Indian Thyroid Society and Endocrine Society of India have partnered together in organizing this meeting. As you can see in the slide, that today we have this meeting till 9 p.m. It is focused on pediatric thyroidology. And tomorrow we are having a session from 11 a.m. to 1 p.m. That is on the World Thyroid Day, focusing on a lot of other aspects, panel discussions and thyroid nodule, and a quiz also for all of you. So next slide, please. Yeah, today we have to have the welcome address. Let me welcome Dr. Narendra Kotwal. He's Lieutenant General retired, and he's a wonderful personality. He's part of the team ESI. He's a president of Endocrine Society of India. Grateful to have you here, sir. He's Director of Endocrinology at Paras Hospital, Panchkula. He's focused on environmental endocrinology as well as spiritual and geriatric endocrinology. He has a lot of publications and a lot of jnana in this field. Welcome, sir. We'll like to hear from you, sir. Please.
Thank you, Mohan. Thank you very much. Dear colleagues, distinguished faculty, esteemed members of Indian Thyroid Society and Endocrine Society of India, and dear participants, namaskar and a warm welcome to each one of you. It gives me immense pleasure to be here on this collaborative academic initiative on the occasion of World Thyroid Day 2025, jointly organized by Endocrine Society of India and the Indian Thyroid Society. Today's focus on pediatric thyroid disorder is both timely and significant, reflecting our shared commitment to addressing endocrine health across all age groups, from infancy to adolescence and beyond. Thyroid dysfunction in children, though less commonly recognized, can have profound and lifelong implications on growth, development, and cognition. Timely diagnosis and nuanced management are critical. Events like today's pediatric thyroid vignette play a crucial role in enhancing awareness, updating clinical equipment, and encouraging evidence-based practices among professionals from both pediatric and endocrine backgrounds. I must commend Pediatric Task Force of Endocrine Society of India and the leadership of Indian Thyroid Society under Dr. Seshadri for curating such a meaningful academic interface. These collaborative educational engagements not only enrich our knowledge pool, but also reflect our intent to work in unison, transcending organizational boundaries for a larger national impact. As President of Endocrine Society of India, I strongly advocate for increased synergy between subspecialty societies. Such alignments make our scientific voice stronger, more unified, and more relevant, especially in the face of emerging endocrine challenges in India's diverse population. Let this World Thyroid Day be a reminder of our responsibility to detect, treat, and prevent thyroid disorders early in life. Let us also strive to make thyroid care accessible, affordable, and accountable from rural clinics to tertiary hospitals. I wish all participants a stimulating and enriching academic experience. Thank you and Jai Hind.
Thank you very much, sir, for that insightful welcome address. I really welcome all of you to have joined today virtually. Next slide, please. Technical team, can you move to the next slide? Can you move to the next slide, Muntaha? Can you hear me? Yeah. So now we have got the president of Indian Thyroid Society, Dr. Krishna Ji Seshadri. He's American board certified. He has also been in the past the secretary of Endocrine Society of India, He's carrying a lot of laurels in his here. He's definitely one of persons who we all look forward in all our conferences. He talks on thyroid nodule. He talks on various aspects of thyroidology, which I think we have to all imbibe across. He's also recipient of so many good orations, and he's editor-in-chief of our own journal, that is Thyroid Research in Practice, International Thyroid Society of Journal, which of Endocrine, Clinical Metabolism and Diabetes. He works as the director of Primer Academy of Medical Sciences and Cleantech. Welcome, sir. We all look forward to listening from you, sir.
Thank you, Mohan. Respected Kotwalji, colleagues, it's an honor for me to be in this meeting. Like many of you, I represent both the societies. I'm a very long-standing member of the Endocrine Society of India. I have served in the EC and have enough scars that every secretary of a society carries. I've also had the honor to be on the president of the Indian Thyroid Society and the editor-in-chief of the Thyroid Society's journal. I consider these as a opportunity that the societies have given me to serve my profession, and also bring those networks and collaborations in place that will allow us to bring in the best of our respective societies to serve our patients, our community, our physicians, and create those nuances and opportunities that build on these. For instance, the ITS actually published, this is not the first collaboration of the ESI and the ITS. Last year, during ESICON, we actually curated a symposium of ESICON on thyroid disease in pregnancy and had it published in the Indian Thyroid Society. So that to me was one of the first sparks of collaboration that brings into it. Why two societies? Because I think there are some intersections of ITS that brings in a little more nuance. The surgeons, the nuclear medicine people, the imaging people, the cytopathologists who are important, and help them mix with the endocrinologists that the ESI brings in. I particularly admire the leadership of Dr. Narendra Kotwal, who has brought in a new dimension into endocrine care and the dimension of spirituality. Many of us are afraid to use the S word, but he wears it on his sleeve, and therefore my pranams to you, sir. When Pramila and then Mohan approached me Mohan and Sri Nagesh approached me about the World Thyroid Day, and I said, it's interesting because we are talking about two vulnerable populations that we are addressing. With Pramila, I had suggested, why don't we do women and thyroid, and that becomes a big focus tomorrow. And then today we are doing children and thyroid, two of our vulnerable populations who are undertreated, underrepresented, and require greater understanding, greater nuance, and greater appreciation. I also want to make a call to all of our speakers. You would have been already approached by Pramila, and I'm just renewing this pledge thing, that please convert today's talks and discussions into an article. The TRP will carry a special a review of these articles and in a symposium format, and therefore your expertise, your wisdom should reach a larger audience that is published. Lastly, I'm making this plea to Dr. Kotwal that I think it is time that we also started doing some collaborative research as a focus from our societies that will start us moving forward. While we may be two different societies, our mission is pretty much the same. Again, this is a
Definitely, Dr. Krishna Sheshadri, whatever your suggestion you have given us, we'll take it forward to its logical conclusion.
It's a great pleasure for me that the society that I run right now, along with my parent society, the Endocrine Society of India, to which I've been a long-standing member, have come together for a purpose. And I hope this partnership lasts for many, many, many years, bringing a lot of help to our members and the community that we serve. Namaskaram. Thank you.
Thank you very much, sir. Very grateful that you have helped us have this webinar today, and thankful to all, both presidents, both secretaries, and all the office bearers of EC, of both the ESI and the ITS for having given this opportunity. So may I just go back to the screen sharing? As the screen gets loaded, let me welcome other dignitaries also. We have with us Dr. Arun S. Menon, who is Senior Consultant Endocrinologist working at Aster Jubilee Medical Complex, Burdubai from last so many months. Welcome, sir. He is my very great professor. I worked along with him at Kochi Amrita. He is previously head of the department at Lisi Hospital, Kochi. He also carries a lot of laurels. He has been a very good, efficient endocrine senior to me. He still guides me every time. Most of us have been his colleagues. You can see that he's done his MBBS from Trivandrum Medical College in 1994. He's done an MD by research at University of Newcastle, UK, 2008-2000, and also he has completed a CCT UK from UK 2004. He's also been awarded the FRCP Edinburgh 2008. Welcome, sir. You are chairing the session today. So may just have a word from you, sir. Yes, sir. Maybe have just a word from you.
Thank you, Mohan. Am I audible?
Yes, sir. Yes, sir.
Okay. Thank you, Mohan. Good evening, everyone. We have heard words of wisdom from Kotwal sir and Krishna Sheshadri ji. And I think the important thing is the collaboration that we are talking about. And we always talk about it quite a bit. But to put it into action, we need people like Mohan and Sri Nagesh and Pramila, who have really taken this forward. I'm sure this is the first step. We have been trying even in the previous years, but I think now there is more meaningful interaction and discussion. I think why this is important is because ITS is a unique organization which has not only got endocrinologists, yes, a large proportion of endocrinologists or large proportion of the organization are endocrinologists. But as Krishna earlier said, it's very important that we extend this to our surgical colleagues who are very much a part of ITS, who have many of the surgeons and nuclear physicians have been even the president of ITS in the past. So the interaction with surgeons, nuclear physicians, pathologists, and other people who do an equally important job in thyroid management, their voices need to be brought into ITS, as well as I think we will all benefit from the fact that these interactions will make us all much better in terms of our clinical practice, in terms of our expertise, in terms of our research interest, as well as finally it will help our patients as well. So I think the work that ITS is trying to do, the collaboration that we try to do with each of these organizations, whether that be ESI, most importantly, but also even the surgical organization and the nuclear physician, which are much, the nuclear physician fraternity is a much smaller organization. But I think we need to, in the years to come, interact more with these organizations and have more collaborative work. So I very much look forward to this. Thank you once again, Mohan and Sri Nagesh, for taking a lead in having these meetings together. I'm sure you guys are, more than able, and we will continue to cooperate and make more meaningful changes to the lives of children as well as women that we are focusing on this World Thyroid Day. Thank you.
Thank you, sir. May we just go back to the screen sharing mode? Yeah. Next slide. So I have been introduced. I am part of the ESI and ITS. I am also doing this program as a convener of the Indian, that is the ESI's Pediatric Endocrinology Task Force. This is one of the first program we are doing along with the partnership. So thank you both teams for having us. Next slide. Next slide, please. Yeah, so as we welcome our distinguished faculty here, Dr. V. Sri Nagesh. He is adult and pediatric endocrinologist working in Hyderabad. Definitely one of our mentors and seniors. He has won the AR Sheth Award 2017. He has the DST registry and he has so many publications, and he's a very good networked individual with a research interest in diabetes, thyroid, pediatric endocrinology, as well as genetics. So welcome, sir. So can we have a word from you, sir? Dr. Sri Nagesh, sir?
Good evening, respected doctors. It's a pleasure to be in this part of this meeting today. Thanks, a huge amount of thanks to Kotwal sir and Seshadri sir who made it possible. This is the first meeting, if I'm correct, of the Pediatric Endocrine Task Force of the Endocrine Society, which was formed recently. And it's a privilege for us to be doing a joint meeting with the Indian Thyroid Society. As a part of this initiative, we are going to have regular webinars from this. Mohan is the person who has been the guiding force behind this. Many of our younger endocrinologists and students have told us that we need more structured, they're getting a good amount of pediatric education, but they also wanted something above and beyond what was being told to them as part of their curriculum. And as part of that initiative, the Endocrine Society and the EC has been kind enough to give us this opportunity to do this webinars in particular areas of interest, which are not part of our routine day-to-day clinical practice. And kudos to Mohan for taking up the initiative. And we are extremely grateful to Kotwal sir, the Endocrine Society EC, Krishna Sheshadri sir, Menon sir, and Premila Kalra ma'am for giving us this opportunity. And we hope we'll go from strength to strength with these programs. And for the first program, I think we've got two excellent faculty here. Mohan will tell us further about this faculty.
Mohan, so maybe have the next introduction slide of the next CV slide. So as the screen gets loaded, I would like to inform you that we have two case-based discussions here. To lead the first panel of discussion, we have with us Professor H.K. Ganesh, who is a very looked after speaker. He is professor and head of AJ Institute of Medical Sciences that is in Mangalore. He is also running the EndoDiet clinic, as well as has got a lot of interest in a lot of conditions like endocrinology, pituitary, thyroid, genetics. He's been trained under Nalini Shah madam at KEM. He's also trained in diabetic foot care at AIMS Kochi, where I was also working. He's done MBBS from Mysore Medical College, MD from SMS Jaipur, and DM from, as I told you, Seth GS Medical College at Mumbai. With him, there is a trainee joining. Next slide, please. He is Dr. Satyavamsi Gade. He's postgraduate in here. So did you hear what I listened? Anybody listen to me?
Mohan, you are not audible for some time. So I think please reach.
Mohan, I think there was an interruption in your network, some signal issue. We didn't hear what you were saying. We could just see the cursor going around. So anyway, you just start again with an introduction of the speaker.
I think Mohan is having a network issue. So
can you hear me?
Yeah.
Will you take over?
Yeah, I'll take over. Mohan, are you there?
No, I think he has a problem. You take over, Ganesh.
Yeah. So at the outset, I would like to thank both the ESI and ITS for giving us the opportunity. And we are grateful to Dr. Narendra Kotwal sir and Dr. Krishna Sheshadri sir for helping us to create this wonderful World Thyroid Day Pediatric Endocrine Symposium, Pediatric Thyroid Symposium. So today we are going to discuss in two parts. The first part will be taken by Dr. Satyavamsi Gade. He's a postgraduate in endocrinology, now doing his endocrinology in AJ Institute of Medical Sciences. Satyavamsi, are you there? So we'll start with the case scenario,
Yes,
then
sir.
two
Yes,
case
sir.
scenarios. Then we'll discuss on those cases, and then I'll discuss few more cases of pediatric thyroid disorders. Then we'll have a discussion. Satyam,
Shall
you
I?
start.
Yes, sir.
Start
Shall I?
sharing.
Sure. Yeah, sure.
Start sharing.
Are my slides visible, sir?
Yeah. Your slides are visible. Put into the
Yeah.
full screen. Yeah.
Yeah. Good evening, everyone, sir. Respected professors and everyone. Today, coming to the first case, she's actually an 8 years, 7 months old girl. She was brought to endocrinology OPD with history of bleeding per vagina 1 week back, and she's having bilateral breast enlargement since 2 months. She's not having any history of development of axillary or pubic hair or exposure to any drugs or any sexual abuse, or she's not having any kind of hypothyroid symptoms such as fatigability, pedal edema, bowel or bladder disturbances, or hair loss, weight gain, dry skin, or developmental delays. She's not even having a recent increase in height. There are no symptoms of raised ICT. There are no history of prior cranial surgeries and no prior radiation exposure, and no prior admissions for any systemic illness. Coming to examination, her height is 117 centimeters on first visit, which is below third centile, and her weight is 25 kgs, which is between 25th to 50th centile, and BMI is 18.3 kg per meter square, and her bilateral breast development is of Tanner stage 2, and without any axillary or pubic hair. There are no cafe alert spot, and there are no other external skin markers, and other systemic examination is within the normal limits. This is her growth chart, where we can see her height is about 117 centimeters, which is below third centile, and her weight is between 10th to 25th centile. This is the image of the girl. Coming to her labs, her LH is on initial visit is 0.09, FSH is 5.61, TSH is greater than 300, T4 is 1.03. Her anti-TPO is 129.8 international units per ml. Ultrasound of both ovaries showed a diffusely enlarged, diffuse enlarged ovaries with large cysts, and uterus is about 5.7 to 2.6 centimeters, and uterine thickness is 4.5 mm. So initially we have started her with levothyroxine dose of about 50 mcg. So after starting her on levothyroxine dose of 50 mcg, and after that we have updated to 75, after that to 100. Her height progressively improved. Now it is between 25th and 50th centile. Coming to summary, she's an 8-year, 7-month-old girl with isosexual peripheral precocious puberty with delayed bone age, and ultrasound showing bilateral large ovaries with primary hypothyroidism, where it can be 1 week Grumback syndrome. So after starting her on levothyroxine 50 mcg, her TSH decreased to 6.82 progressively, T4 increased to 5.93, and ultrasound the bilateral large ovaries with cyst resolution happened, and it came to the bilateral ovaries came to normal size, and her TSH came to 6.82 and T4 came to 5.93. Coming to second case, he is an 13 years old boy. He came with history of poor height gain. There is no history of fatigability, pedal edema, or bowel and bladder disturbances. No history of hair loss, weight gain, dry skin, or developmental delay. No history of recent increase in height. No history of symptoms of raised ICT. No history of development of axillary and pubic hair. No exposure to drugs. No sexual abuse. No history of raised ICT symptoms. No prior history of cranial surgeries or radiation exposure. No other admissions previously for systemic illnesses. His height on examination is 127 centimeters, which is below third centile. His weight is 37.5 kgs, which is at 25th centile, and his BMI is 23.25 kg per meter square, and rest of the systemic examination is within normal limits. Coming to his testis, his bilateral testicular size is between 6 to 8 cc, and his stretch penile length is about 5 centimeters, and there is no axillary pubic hair on examination. Am I audible, sir? Hello.
Yes,
You're
you're
audible.
audible.
You're audible. Go ahead. Go ahead.
Yeah. Yes. So this is his growth chart. His height is about 123 centimeters, and it is below third centile. And his weight is between 25th to 50th centile. This is the X-ray. X-ray of his left hand wrist AP view, showing his bone age of about 5 years 6 months. His hands shows there is bilateral enlargement of both hands, and there are hypothyroid phases. This is the complete picture of the boy. Coming to his bloods, his TSH is greater than 100 and T4 is less than 0.01, and we have started him with thyroxine of 50 mcg initially. Coming to summary, he's a 13 years old boy with poor height gain, with isosexual peripheral precocious puberty, or we can say that incomplete precocious puberty, with bone age lagging behind chronological age, with primary hypothyroidism. It can be taken as a counterpart, male counterpart of the Van Wyk-Grumbeck syndrome. Come to discussion. Peripheral precocious puberty is generally GnRH independent, and incomplete isosexual precocity can be due to premature increased sex hormone secretions, such as in case of any HCG or health secreting tumors, or iatrogenic exposure to gonadal steroids, or because of Max-Albert syndrome or juvenile hypothyroidism. Coming to Van Wyk-Grumbeck syndrome, it is actually characterized by juvenile hypothyroidism, delayed bone age, and isosexual precocious puberty. Coming to pathophysiology of it, actually high in females because of high TSH levels, it leads to FSH-like action on the FSH receptors in the ovary because of the common alpha subunit being shared by the TSH and FSH. And this thing is even supported by the specific FSH estrogen dominant clinical picture in the individuals. The increased levels of TSH, they act through the FSH receptors by a specificity spillover effect, and it induces FSH-like effects on the gonads. It leads to multicystic ovaries, uterine enlargement with bleeding, and breast enlargement. And increase in estradiol levels leads to ovarian hyperstimulation, precocious puberty, metrorrhagia, ovarian cysts, and development of secondary sexual characters without pubic and axillary hair development. Coming to the pathophysiology in the males, the study by Frank Villa et al., they have indicated that hypothyroidism leading to high TSH, while this FSH action, it leads to excess proliferation of Sertoli cells and testicular enlargement. And male patients, they will be having macroorchidism without any obvious virilization. And testicular histology also, it shows FSH predominant picture, that is predominance of tubular structures will be there without increase in Leydig cells, and there will be enlargement of coming to the biochemistry picture in Van Wyk-Grumbeck syndrome, there will be low FT4 levels, high TSH, high estradiol, and high prolactin levels. And this hyperprolactinemia occurs because of unexposed secretion of prolactin due to elevated TRH. And this prolactin in turn leads to increase in sensitivity of ovaries to gonadotropins, and also it slows down the GnRH pulse frequency. Coming to radiological features, there will be enlarged ovaries with singular and multiple cysts. There will be pubertal uterus, delayed bone age, and there can be pituitary hyperplasia also. Treatment is with levothyroxine, and prognosis is good once the treatment is established. That means all the symptoms which are there, I mean the pubertal stage can be transformed back to pre-pubertal stage with just the treatment with levothyroxine, and the clinical manifestations will disappear, and secondary sexual characteristics also will regress. And early recognition and prompt treatment is required so that for the child can attain a normal final height. And surgical therapy is only for complications such as ovarian torsion. And early diagnosis is important because to avoid unnecessary diagnostic and therapeutic procedures by taking it as ovarian tumors, some may go for surgery. So to avoid all this, early recognition is important. How to differentiate it from other precocious puberties? Actually, the discrepancy in bone age and height is one of the things. In children with precocious puberty, commonly there will be advanced bone age and pubertal growth spurt will be there. Whereas conversely, in Van Wyk-Grumbach syndrome, they'll be short with delayed bone age and there will be lack of growth spurt. So that is the main characteristic point to differentiate between other causes of precocious puberty. Coming to conclusion, the pathophysiology, it involves a complex mechanism which is mediated mostly by action of TSH and FSH receptors. So early recognition and initiation of thyroid hormone replacement causes reversal of all the symptoms with normalization of hormonal profile. It also avoids further diagnostic tests, fear of malignancy such as ovarian tumors and or HCG or LH tumors, and it also avoids unnecessary surgery. These are my references. Thank you.
Thank you, Satyamshi. So these two cases were presented mainly to emphasize the importance of early diagnosis of this kind of hypothyroidism presenting with the precocious puberty. In fact, many times the referrals we get from pediatric endocrinology or pediatric surgery department rather, pediatric surgery telling that there is a large ovarian cyst. We are planning for surgery, either give fitness or just evaluate endocrine part. And second thing is sometimes this child was referred, the CA 125 levels also was very high. CA 125 can be very high in 1 week Grumbach also. So which can be taken as a marker of malignancy and can lead to unnecessary surgery. So that is the reason the proper and early diagnosis of this condition is very, very important. So next,
Yeah, welcome, sir. Can you hear me?
Yeah.
Yeah, because I have a network issue because of the rains here, because cyclone had almost come. So sorry for that. So I'll continue with this discussion. Thank you very much for that short and sweet presentation. We are all available for interaction. If you have any doubts regarding this case or interesting other cases, if you have any interesting case to share, the residents, whoever joined on YouTube, please share your thoughts on that. We'll be able to convey to the panel. So moving on, let me go back to the audio, technical team for the screen sharing. Can you share the next CV? Muntaha, are you here? Can you hear me?
Mohan, shall we take up questions or?
Yes, sir. Yes, sir. Please, sir. Any questions we have, please, I'm welcome. Because I thought if we have ready with the screen sharing, we can do that in the end also.
No,
as you wish, sir.
No, yeah. I think I have few more cases to present. So from my side,
okay,
I'll put a few more cases of pediatric thyroid disorders. Then we'll move on to case discussion.
Okay, sir. I thought we have finished. I thought we have finished. Okay, sir.
No.
Okay, sir.
Few more cases we'll discuss. Then we'll have question and answer.
Till this point, I think we have not received any questions. So you can carry on, sir.
Yeah. Sure. So good evening, everyone. Just now we heard from Dr. Satyamshi the presentation of hypothyroidism with Van Wyk-Grumbach, the presenting as ovarian cysts and premature menarche. So now I'll share few more pediatric thyroid disorders like which presented with juvenile age group, atypical presentations. When I started my career, I thought I know everything in pediatric thyroid disorders. My confidence level was very high. Then as the years passed by, so I came to know that it is not that simple. It is pretty complicated. So this actually, can you guess the age of this child? She was brought to my OPD in Mangalore. So in fact, he had subnormal intelligence and he passed urine in front of me. So that was the state actually. So he was carried by his mother. So he was age 16 years. He was age 16 years and his height was only 105 centimeters and totally subnormal intelligence he was having. So he was diagnosed as hypothyroidism at the age of 2.5 years, probably congenital hypothyroidism only. So the TSH was sky high, but he was started on thyroxine at that time. but there was no probably proper guidance, or the parents didn't understand. So they discontinued, and he was brought at the age of 16 years with this kind of state.
16 years, sir.
16 years. So
Okay,
sorry,
okay.
state of affairs. Even now, it happens in India.
So what happened finally? Did he reach target height, sir?
No. So actually, once again, they lost to follow up. They are coming from the Coorg area, so they lost to follow up. And currently, I don't have his follow up, but
Okay.
they came only once or twice after that, and there was some improvement in height was there.
Okay, so that means a missed opportunity by the local whoever has seen the child.
Yeah, and probably the parents were not educated enough
Not able to.
the importance of hypothyroidism in childhood.
Yes, sir. Yes, sir. Okay, sir. Thank you, sir. Next case.
So moving on to the second case, is an 8-year-old girl. She was short, but unlike the previous case, she was very good in studies, and there were no hypothyroid features at all. And when we ran the lab, it was TSH was more than 100, and she had primary hypothyroidism. So importance of this case here, the children can present only with short stature. Short stature may be the only manifestation, and there may not be any other hypothyroid symptom. So all short children, whatever may be the diagnosis you are thinking, just run the thyroid function, because you may be missing hypothyroidism in them. So that is a dictum. Hypothyroidism should be ruled out in all children with short stature. So third case, 12-year-old boy presented with muscle weakness, and on examination he had proximal muscle weakness also. So the myopathy, muscular dystrophy, all these were the differentials, but TSH came more than 100. So this is classically described as Cocker-Deber-Semelin syndrome. In adults, it's called as Hoffman syndrome. So the presentation can be only muscle weakness, aches, and cramps. And in fact, many a times the school children complain of these symptoms, and many a times it is attributed to excess physical activity or sports in the school. And this has to be kept in mind. So the thyroid function should be asked whenever there are muscle-related symptoms in children. Next, 15-year-old girl presented with severe headache, aggravated since the last 2 weeks, no vomiting. So she was presented to pediatrics, then neurology. So then the MRI was done. MRI showed a large pituitary macroadenoma. So during the macroadenoma workup, FSH-LH was on the lower side, cortisol was normal, prolactin was 27 nanogram per ml. So thought probably hook effect, or maybe the stock compression it was thought. Then finally the thyroid function was ordered. You can see the thyroid here, the thyroid function, TSH more than 150 and T4 of 3.5. So the possibilities are thyrotrophic adenoma or non-functioning pituitary adenoma with primary hypothyroidism. So the possibility of thyrotrophic adenoma is more likely here because the enlargement is quite diffuse. If you can see the MRI, it's a diffuse enlargement. So there is no stock deviation, or it's not unilateral swelling. So with the TSH of more than 150, very likely that it is a thyrotrophic adenoma. So she was started on thyroxine 100 microgram per day. She improved symptomatically in 2 months, and we can see after 6 months her MRI was like this. We did the MRI, so the adenoma disappeared.
Okay.
Suffice
so
to say
usually,
that
usually what happens in pituitary adenoma, the TSH will be suppressed or less. TSH will be less usually, no? T3, TSH and T3, everything will be low. But this case, I think the catch was the high TSH and not properly given. So that is why you put macroadenoma as a misguided, no? Maybe. So if
actually the patient was seen by the MRI was done first.
No.
The thyroid function was done later. So otherwise, when that is the reason. So it is not as rare as previously thought. The thyrotrophic adenomas. But usually when the TSH is very high, we don't ask for MRI because we never think thyrotrophic adenoma as the cause of headache, or even if we are thinking, it doesn't make any sense. So that's why we don't ask for MRI. But in this case, the patient was evaluated by a neurologist first. So that is the reason MRI first, followed by thyroid function. So this can happen. And sometimes if the thyroid function is not properly evaluated, then the patient might end up with pituitary surgery also, because stock compression or prolactinomas, hook effect, all those things might be thought. And without proper endocrine evaluation, if it is evaluated only by other departments, the patient might end up with surgery also. So that is the reason you should always think of this when the TSH is more than very high and a diffuse enlargement, we have to think this as the one of the differential. Next case, 16-year-old unmarried girl presented with irregular cycles, galactorrhea, prolactin was 45. So once again, the prolactin was run in dilution also. It also showed almost similar. There was no major change. Around it came out 55. The FSH 2.5, LH 2.8 on the lower side. So the thyroid function, you can see once again the T4 was slow, 3.5 and TSH 95.3. So again suggesting that there is a increased TSH, the spillover effect, increased prolactin leading to galactorrhea. So in all patients with hyperprolactinemia, we have to rule out hypothyroidism. Otherwise, we can miss and unnecessary imaging and unnecessary investigations will be done. And another case, 12-year-old girl presented, she was referred as she was overweight. You can see here, she was very much overweight. BMI was 32.4 and T4 was 8.6 and TSH 7.3. So very, very important thing we have to remember, all the weight gains are not due to hypothyroidism. Here, because of the obesity, increase in leptin levels, leptin itself increasing the TRH, thus increasing the TSH. So the moderately elevated TSH can be seen in up to 10 to 23% of obese children, and most of the times it will be associated with normal T3 and T4. So weight loss itself is enough. It will normalize the TSH and other thyroid hormones if they are abnormal also. Leptin is the most common link between obesity and increased TSH. So high TSH in childhood obesity associated with normal T3 and T4 levels should be treated only with the weight loss measures and lifestyle modification and not with thyroxine. Last case, a 14-year-old girl, menarche at the age of 12 years. Parents noticed a swelling in front of the neck since 2 months. No family history. TSH just elevated 9.1. So it's a here actually. I have video also. I didn't put. So it was a submental thyroid, big thyroid presenting in the age of adolescence, during adolescence because of the increased demand. So these are the possible causes of mildly elevated TSH in the childhood period. Hashimoto's thyroiditis, ectopic thyroid, other medications like anti-epileptics, various syndromes, and it can be TSH receptor mutations or CKD. So I will not go into the details. So subclinical hypothyroidism in children. So mainly what we have to look into is the history of any autoimmune or genetic disorders in the family history of goiter or endocrine or other genetic diseases, and physical examination we have to look into goiter, and mainly whether we have to see whether it is autoimmune by asking for antibody levels, and if not in a hurry, we can wait for 3 to 6 months. So risk of progression we have to estimate, and depends on the underlying condition, it will vary. So if the anti-TPO antibody levels are positive, then very likely that they will progress. So levothyroxine therapy is indicated only in severe subclinical hypothyroidism, that is TSH more than 10, presence of goiter or symptoms of hypothyroidism. Including my presentation of atypical presentations of juvenile hypothyroidism. Atypical presentations are very common in the juvenile age group. Musculoskeletal symptoms are quite common. And we have to remember that weight gain is not due to hypothyroidism many a times. And treatment with levothyroxine is very effective in majority of the patients with juvenile hypothyroidism. Thank you.
Thank you, sir. Very, very, very enlightening. And each slide had a message, actually. That is what I like. Your first case had a message. All the cases had a message, very good message as well. So I request you to just, we'll just see whether we have some interaction. If there are any questions amongst the faculty also, please feel free to interact because we have time. Dr. Sri Nagesh, Dr. Arun Menon, sir, who is there in the faculty group, please feel free. Arun Menon, sir, is also here. Any points to add here, sir? Dr. Abha, or anybody else has got any points to add?
No, not at this point. Dr. Ganesh's cases were very clear and very, I think they have conveyed the message as you rightly said. So yeah, let's wait for others' opinion.
Thank you, sir. So we'll receive the questions soon. I think I am hopeful. Any technical team, can you just post in
Sir, you're not audible.
I think Mohan is lost again. So can you put the next speaker's CV slide, Dr. Abamoni?
Yes, sir. Sure, sir.
So, Dr. Mohan, are you there?
Can you hear me?
Yeah. You're audible now.
Because there is some technical issue.
No issues. No issues. Go ahead, Mohan.
Yeah. So I just very pleased to listen from you. So technical team, any questions are there in the audience? Please share in the. We'll take it up together. Okay.
Sure, sir.
Okay, thank you. And so we'll go to the next discussion. Welcoming Dr. Abamani Baro. She is the associate professor at Guwahati Medical College, Guwahati, Assam. She's a very close friend of mine. She's also been trained in MD Pediatrics and DM Endocrinology like me. She's also working at Pratiksha Hospital, Guwahati, as well as Arya Wellness Center. She will have a trainee presenting today with her. Next slide, please. Can you hear me? Next slide, please.
Yes, sir.
Yeah, with her presenting is Dr. Anu Tiwari. She is third year DMH student in endocrinology at Guwahati Medical College and Guwahati Hospital. Welcome, Dr. Anu, and over to you. This case will be focused on pediatric thyroid nodules, algorithmic approach. It will be lecture. So over to you both. Can you hear me? Over to you both. Yeah.
Thank you, Mohan sir. A warm good evening to everyone. So I thank ESI and ITS for giving me the opportunity today. And I thank Dr. Kotwal sir and Krishna Seshadri sir for the platform and the opportunity. And yes, Mohan sir, Ganesh sir, Srinagi sir, Arun Menon sir, and everyone present here. Today we will be presenting how to approach pediatric thyroid nodule. We will have few cases as a case scenario, and then we will discuss about the algorithm. So to present this, I invite Dr. Anu Tiwari. She is a DM trainee in the Guwahati Medical College, Andhras. And over to you, Dr. Anu.
Thank you, ma'am.
Yeah, please share the slides. Dr. Anu, any problem? You go to share content. Technical team, can you share the slides if you have that with you?
Munta, you are in the group, no? Can we just take some time and take the slides from the group? You are at the same WhatsApp group. Yeah, we'll wait for some time. Meanwhile, I'll just request Dr. Ganesh and Abba to please interact if you have some interesting issues to handle. Daily, we see so many thyroid cases in our practice. So I think the thyroid nodules and thyroid discussions are quite often seen. Yeah, so screen is on. So may I just full screen now? Is it through Anu's or is it through Munta's? Whose screen it is?
This is mine, sir. I'm sharing the screen.
Dr. Anu is sharing the screen. Okay.
Yeah.
So
make it full slide.
Full screen mode.
Yeah. Full screen.
Yeah, sure. Is this fine?
Yes, perfect. Go ahead.
Good evening, respected faculties and my dear colleagues. Today I'll be presenting a few cases. Then we will talk about the approach to pediatric thyroid nodule, and I'll be presenting 4 cases to be precise with varying presentations in childhood presenting with thyroid nodule. So first case I will start. This is a case of 10-year-old girl who is presenting with anterior neck swelling noticed since 1 year that has been gradually progressive in size with no local compressive symptoms and no features suggestive of hypo or hyperthyroidism. There has been no history of any fever, URT or radiation exposure or any family history of any other thyroid illness or thyroid tumor or any other non-thyroidal tumors. Child's birth and developmental history has been normal. She is currently in 5th standard and is doing good academically, and she is growing well with adequate height and weight gain with a Turner stage of B2. That is, she has entered puberty with P1 and with absent axillary hair, and she has not attained menarche yet. She is a patient. Now on thyroid examination, she had a nodule that was a solitary nodule that was palpable in the left lobe of thyroid. That was around 1 by 1 centimeter in size, non-tender, mobile, soft in consistency, and with no cervical lymphadenopathy. Rest thyroid gland on palpation was normal. Coming to the investigations, her routine investigations, that is CBC, RFT, LFT, everything was normal. We did a thyroid profile that was suggestive of subclinical hypothyroidism with a TSH level of 7.4 and a normal pre-T4 in 230 levels, and a TPU positive. That was 38 units international possible with a cutoff of less than 10. So we went ahead with USG neck also. USG neck was suggestive of a well-defined cystic nodule that was 1.5 by 1 centimeter with smooth margins, mixed solid cystic lesion with and hypoechoic wider than taller, with no calcification in left lobe of thyroid, and that was thyroid 3. Since now this patient was already has undergone FNSE also, and it was showing a colloid goiter. So to summarize, it was a case of solitary thyroid nodule presenting with subclinical hypothyroidism with anti-TPO positivity. Now, in such cases, we usually face dilemma whether to start levothyroxine in such cases or not. Since the FNSE was not suggestive of any malignancy, and it was a colloid goiter, that was a benign, benign finding. So we did not. There was no need of any surgery or any thyroidectomy in this patient. The doubt was whether to start thyroxine or not. So in pediatric subclinical hypothyroidism, there has been always a debate regarding this thing. There have been studies recently in which it has been shown that children with Hashimoto thyroiditis had a beneficial effect of levothyroxine in goiter, and even in patients who had a normal or subclinical thyroid dysfunction. This was recently this was published in JCM article a few years back, and then there is another study that says that thyroxine prevents goiter formation in chronic autoimmune thyroiditis. So we started on thyroxine, and now will this thyroxine treatment have any effect on nodule size? So regarding this also, there has been one recent study that was published last year, and it was done in Greece. Which was suggestive of that concluded that after initial levothyroxine therapy, thyroid nodules disappeared in around 85 to 85.5% patients and did not reappear throughout follow-up. And in 14.5 patients, 14.5% patients, these nodules remained the same or increased in size, but they decreased after subsequent thyroxine administration with an increased dose. So in such conditions, we can go ahead with supplementation of thyroxine. Coming to the next case, this is a case of a 13-year-old girl who is also presenting with a complaint of anterior neck swelling that she has noticed since 2 years, and it has been gradually progressive in size. Now, this patient also had history of palpitations, hyperdesiccation, heat intolerance, and weight loss, but no local compressive symptoms and no history of any fever, URTI, radiation exposure, or family history. Her birth and developmental history has been normal, and she is in 8th standard, doing good academically with a height within 25th to 50th centile and weight that is on the lower side, that is between 3rd to 10th centile, and she had history of some recent weight loss also. And she had entered puberty with a Turner stage of B3, P3 and axillary hair were present, and she has not attained menarche yet. So on examination, the patient had tachycardia, pulse rate was around 100 per minute, fine tremors were present, but otherwise she was not in heart failure with a normal JVP, with no fetal edema, with respiratory and cardiovascular systems normal examination, with a CAS score of 0 by 7 in both eye, with a normal visual acuity and normal fundus examination. Thyroid examination was suggestive of a diffusely enlarged thyroid that was grade 2, with single nodule palpable in left lobe of thyroid that was around 1 by 1 centimeter, and it was non-tender, mobile, and soft in consistency, and with low cervical lymphadenopathy. Coming to her lab investigations, her routine investigations were normal. Her thyroid profile was suggestive of thyrotoxicosis. That was low TSH, that was 0.003, with a pre-T4 level that was 7.23, and with an upper limit of 1.75 and a total T3 of 10 with upper limit of 2.1, and a TRAP was significantly positive with a level of 40 international units per liter. Her USG leg was suggestive of both lobes of thyroid were bulky and heteroechoic with a prominent internal vascularity that was more very suggestive of Graves, and as well as TRAP positivity was suggestive of Graves and her history also. But there was single nodule of size 1 by 1.2 centimeter with smooth margin, hyperechoic, cystic, with no calcification in right lobe of thyroid was seen. So thyroid's 2 lesion was there in the right lobe, and in the left lobe 1 by 1.2 centimeter nodule was seen with smooth margin, hypoechoic, mixed solid cystic lesion with no calcification. That was thyroid 3. FNSA was done in the left thyroid nodule, that was Bethesda category 3. Now, in these patients, this basically was a patient with Graves' disease with nodularity. So, in these cases, how to proceed further? First of all, how common is nodularity in Graves' disease is this data in pediatric population is not much available. It is more studies have been done in the adult age group. So in a pediatric group, a recent one study done by Kovacs et al. In 2015 was had concluded that thyroid nodules were seen in around 41% of pediatric Graves' disease patients, and the risk of malignancy in these nodular Graves' disease in pediatric age group was around 22%. The risk factors associated with Graves will be radiation exposure, family history of thyroid cancer, iodine deficiency and excess. Coming to the adequate iodine intake will be for the pediatric group as per the WHO and IGN. It ranges from 90 to 150 depending on the age group. And iodine, to define iodine access, WHO has given the range that is upper limit of iodine intake that is considered normal, ranges from 150 in initial 0 to 6 months in infancy. That will be microgram per kg per day, and progressively decreases. That is by the age of 12 years, around 30 microgram per kg per day is the upper level of iodine intake. And to define iodine deficiency, urinary iodine concentrations have been cut-off concentration values have been published by WHO, and an adequate level is defined as 100 to 199 microgram per liter in school-age children, that is more than equal to 6 years. Coming to case 3, this is a 16-year-old girl with again anterior neck swelling with 1 year, since 1 year, that is gradually progressive in size. She had history of palpitations and heat intolerance. Her birth history, developmental history, and height and weight growth velocity has been normal. She has a normal puberty, B5, P5, and menarche attained that 13 years of age with normal cycles and regular flow. Regular cycles and normal flow, and with no history of any fever, URT, radiation exposure, family history of thyroid illness or tumor. On examination, she was she did not have any heart failure signs, and no fine tremors, no thyroid-associated ophthalmopathy. Only pulse rate was on the higher side, that was around 100 per minute. That was regular. And on thyroid examination, there was a solitary nodule palpable, 2 by 3 centimeter, non-tender, mobile, soft and consistency, no cervical lymphadenopathy, and rest of the gland was normally palpable. Coming to her lab investigations, routine investigations were normal. Now her TSH was showing mild cytotoxicosis with a TSH level of 0.02, free T4 of 2.1, with an upper limit of 1.75. Total T3 was 2.5, upper cutoff of 2.1, and anti-TP was negative, and anti-TP was not required, TRAP was negative. In USG neck, we can see there was a thyroid 3 lesion. So there was a thyroid 3 lesion that was a well-defined solid cystic lesion that was 2.2 by 3.5 centimeters, smooth margin, hypoechoic, and wider than taller lesion with no calcification seen. So it was a thyroid 3 lesion with no lymphadenopathy, and her SNSE was suggestive of, her scintigraphy was suggestive of increased uptake in thyroid nodule. Since this patient had a low TSH, we went ahead with the thyroid scintigraphy, and her TRAB was also negative. And her thyroid scintigraphy was showing an increased uptake in a single nodule, suggesting that there was a hyperfunctioning solitary nodule in this patient. So this patient was diagnosed as having autonomous thyroid nodule. Now, in these patients, treatment options remain to be either hemithyroidectomy can be done as per the ETA guidelines, or lobectomy can be done as per the American Thyroid Association guidelines. Usually, this is the one of the points that differ from the adult management part. In adults in toxic adenoma, radioiodine is the one the treatment of choice. But in pediatric group, usually radioiodine is avoided or can be considered in very small nodules. It is because in the pediatric age group, this low level of radioiodine will again become a risk factor for developing malignancy. So usually radioiodine is avoided in these autonomic thyroid nodule cases, and usually hemithyroidectomy is preferred as per ETA guidelines. Otherwise, lobectomy can be done as per ETA guidelines. And as per ETA guidelines, these patients can even defer surgery if in case they just have subclinical hyperthyroidism, that is just a low TSH with no thyrotoxic symptoms and a normal T4 and T3. And antithyroid drugs and beta blockers can be given in case patient is having thyrotoxic symptoms and is clinically not stable or having severe thyrotoxic symptoms. Then coming to the fourth case, this is a 16-year-old girl with neck swelling since 1 year, gradually progressive, no local compressive symptoms, no hypohyperthyroid symptoms, no fever, URTA, radiation exposure, and family history. Birth developmental history is normal. She is in 10th standard, doing good academically, and height is between 50 to 75th centile, weight is around 2 to 10 centile, with a normal pubertal development and normal menarche at 13 years of age with normal menstrual cycles. Her thyroid examination was suggestive of solitary nodules 1 by 1.5 centimeter, that was non-tender, mobile, and hard in consistency. Rest examination was normal. Rest thyroid gland was normal only, but bilateral cervical lymphadenopathy was present at levels 2, 3, 4, and 5. Her lab investigations were suggestive of only a suppressed TSH that was 0.02 with a normal T4 and total T3 levels with a negative trap. And the routine investigations were normal. USG neck was done, that was suggestive of hypoechoic well-defined nodule that was 1.2 by 1.8 centimeter, that was taller than wider, smooth margin, mixed solid cystic lesion, and having peripheral rim calcification. So it was a thyroid 5 lesion with bilateral lymphadenopathy involving both involving 2, 3, 4, 5, and 6 levels, and largest was measuring 2 by 2. Then FNAC was suggested to Bethesda category 5, and that is suspicious for malignancy. And scintigraphy was also corroborated the FNAC reports by showing no uptake in the thyroid nodule, suggesting that it is highly suspicious to be malignant. Our diagnosis was solitary thyroid nodule with a Bethesda category 5 with bilateral cervical lymphadenopathy, most likely to be malignant. So next was this patients. Now this since it is suggestive, highly suspicious of malignancy, so these patients will require total thyroidectomy only, and along with the central and lateral neck dissections depending on the lymph node involvement. So these are the cases. Then moving forward to the approach to pediatric thyroid nodule.
So for any pediatric thyroid nodule, so usually in pediatrics, thyroid nodule, in most of the cases, in 80% of the cases, it will be asymptomatic, and only in 20% of the cases, it is symptomatic. So majority 80%, it is asymptomatic. So many a times the parents do come with the child with like incidentally detected thyroid nodule or an increasing size of the thyroid gland or a goiter. So they may not have any history suggestive of hyperthyroidism or a hypothyroidism. So when we see a patient with thyroid nodule, clinically we have to examine the patient. We have to take a detailed history. Family history is very, very important because a family history of thyroid cancer can give us a clue to a familial type of thyroid cancer or an MTC. So a family history of thyroid cancer, family history of goiter is very, very important. Even family history of pheochromocytoma also has to be taken. Onset duration and progression is very important for the thyroid nodule. If it is a rapidly progressive, then yes, it is more suspicious. We need to know the onset, whether it is associated with pain, whether it is associated with other features like firmness or hardness, increasing hardness. So all these things has to be taken into the history. So when we examine the child with a thyroid nodule, coming to you with a thyroid nodule, clinically, we have to see whether the child has features of hypothyroidism or hyperthyroidism. As Dr. Anu has already mentioned, we can have the features of Graves' disease, like there will be a tremor, palpitation, there will be eye symptoms or eye signs as well. For hypothyroid, again, we can have, in the previous juvenile hypothyroidism session, we had features like the patient or the child may be having features of hypothyroidism like mixed edema. The child may be having a short stature, delayed puberty, or a precocious, pseudo-precocious puberty. So vitals are very, very important. The heart rate or the pulse rate, let us see the tachycardia or bradycardia. So vitals are very, very important. The body proportions are also important because in men too, we may get a marfanoid, and marfanoid habitus may give a suggestion towards men too, or the syndromic conditions. Moreover, we can also look for hypercalcemic features because in MEN, they can also have hypercalcemia, although hyperparathyroidism, sometimes they present with hyperparathyroidism as well. Again, we can also look for mucosal neuromas. We can look for macrocephaly because in the syndromic varieties, we can get the macrocephaly, short stature, hypogonadism, delayed puberty as well. Also, we have to look for Carney's complex. So for lentigens, skin is also very, very important. Dentition is important because in dentition also, we have seen that in some of the syndromes like familial polyposis adenomatosis, in those cases, patient may develop delayed dentition or there is supernumerary dentition as well. So when we get a suspected thyroid nodule, an ultrasound has to be done in such cases. So this is the only way we will get some idea about what is the type of the nodule. And once we see, so size is never a criteria. So be it less than 1 centimeter, be it more than 1 centimeter. So unlike in adults, we don't have a size criteria in pediatrics. So a nodule with a suspicious features, which I will be telling in subsequent slides. So we have to again decide on whether they are high suspicious of malignancy or low suspicious of malignancy. So with the nodule, we also do a TSH. If TSH is suppressed, then we can do a scintigraphy. If we get autonomous nodule with high uptake, we can go for a hemithyroidectomy. Because in autonomous nodule also, the risk of malignancy is higher in children. Again, if we can also, if suspicious, we can do a calcitonin levels if there is a family history. And if calcitonin levels are severely elevated, then we know this is suspicious of MTC. And we need a prophylactic total thyroidectomy. If calcitonin is mildly elevated, then again, or any suspicious nodule, we go for a FNAC. Again, FNAC or FNB is categorized or it is classified or staged according to the Bethesda classification. Next slide. So this is, what the risk factors, the high risk cases, what are the risk factors for DTC? So a positive family history, as I have already mentioned, if there is chronic iodine deficiency or iodine excess, if there is a previous history of exposure to ionizing radiation, especially in children who like ALL and other type of childhood cancers who have received some type of radiation, again, they are at higher risk of DTCs. And if there is a history of autoimmune thyroiditis, especially lymphocytic thyroiditis with positive antibodies, and in syndromic cases, as I have already mentioned. So the syndromes specific to children are PTN hematomas, DICER1 gene mutation, familial edematous polyposis, then the Carney's complex, even Warner syndrome is also associated with high risk of DTC. Next slide. So there are a lot of causes of thyroid nodule, as we have already seen, a multinodular goiter or a single node. It could be a DTC, papillary thyroid cancer. Papillary thyroid cancer accounts for the maximum, almost 80% of the thyroid cancers in children, and anaplastic thyroid cancers, polydifferentiated thyroid cancers, they are very, very uncommon or rare. And anaplastic thyroid cancers are very, very rare in children. Even Hashimoto's thyroiditis can also come with it. If subacute thyroiditis can come with a thyroid nodule, toxic adenoma, autonomous thyroid nodule, even a cyst, a colloid cyst, simple or hemorrhagic cyst can also come with a thyroid nodule. Sometimes we have seen thyroid abscess coming, but then again, thyroid abscess will have a painful nodule. The child will be toxic, there will be fever and other systemic signs. So even thyroid lymphomas have been seen. The syndromes can be coming with this type of a nodule. It could be familial non-medullary DTC, it could be men-associated MTC or a metastatic carcinoma as well. Next slide. So we know that any suspicious or a child with a nodule, we have to do an ultrasound. So whether thyroid nodule is benign or there is a risk of malignancy, we can get an idea from the ultrasound. Although ultrasound alone cannot definitely differentiate between benign and malignant, but we can combine ultrasound, FNAB, and the histology in FNAB or the molecular genetics or oncological, the molecular genetic analysis in the FNA aspirate to identify that we are dealing with a malignant or a benign nodule. So whether thyroid nodule needs FNAC, we can get an idea from the ultrasound. Whether there is lymph node involvement, we know by ultrasound, and whether lymphadenopathy looks benign or there is a high risk of malignancy. This information will also be given us by the ultrasound report. Next slide. So for a thyroid nodule, hypoechogenicity, this is associated with thyroid risk of malignancy. So hyperechoic or isoechoic, they do not have much of risk of malignancy, but yes, if you have a hypoechoic nodule, the risk of malignancy is high, and also the specificity is between 50 to 84%. If there is calcification, specifically macro calcifications, punctate echogenicity, so all these calcifications again have a high specificity. Taller than white, irregular margin, increased vascularity, and again, all this have a high specificity. Again, combined radiological features give a specificity up to 100%. Even if we combine these radiological features, the sensitivity goes as high as 93%. So we should always combine these radiological features. In the adult guideline, even like the Indian Thyroid Research, even the journal, that is Indian Journal on Thyroid Research and Thyroid Research and Practice, in 2024, there is an adult review and guideline on the thyroid nodule in adults. In that review article also, there is very nicely given as how we can give points to each of this and how we get a combined radiological count or point for evaluation of the thyroid nodule. So next slide. So again, for a lymph node, if there is microcalcification, so we should always remember it is macrocalcification in the thyroid nodule and it is microcalcification in the lymph node, which suggests malignant involvement. So microcalcification has a high specificity. Cystic changes in the lymph node shows a high chance of malignancy. Whereas in a thyroid nodule, cystic changes have the least chance of malignancy. Then comes spongiform, then comes solid, and then comes a mixed, and then comes the solid. Solid form has the highest, but it is not in case of lymph node. It is a cystic aspect that increases the malignant potential of a lymph node. Peripheral vascularity, again hypoechogenicity, and the round shape. It has high specificity. Next slide. Now, which thyroid nodules in children need FNAC? So any child who is young, that is less than 20, the risk of malignancy is very, very high if the child is less than 14. So in children who are young, less than 18, the pediatric and adolescent age group, if they are male sex, if it is rapidly progressive, if there is a history of neck radiation, cancer survivors, if there are compressive symptoms, progressively increasing size, and a family history of MEN2, this history suggests that this thyroid nodule could be a malignant thyroid nodule and need a FNAC. If the lesion is hard, if it is fixed, there are compressive symptoms like this change of voice, dysphagia, dyspnea, irregular consistency. If there is already a vocal cord palsy, hoarseness, persistent regional lymphadenopathy, this suggests that we should do a FNAC. Again, ultrasound features, as I have mentioned, if there is hypoechogenicidity, increased vascularity, calcification, punctate echogenic foci, irregular margin, tolerant and white, and lymph node suggestive of a feature suggestive of malignancy. So if these are present, there is no size criteria in children. So even a 5 millimeter nodule, you need to get a FNAC done. Next slide. Now, this is the Bethesda criteria. We all know the Bethesda criteria. It has categorized from 1 to 6. 1 is non-diagnostic. We have to repeat it another 3 months. After 3 months, 2 is completely benign. Most of the time, our lesions are benign. 3 is atypia of undetermined significance. 4 is follicular neoplasm. 5 is suspicious of malignancy, and 6 is malignant. So 5 and 6, we know that we have to refer the child for a surgery. But then again, 3 or 4, the risk of malignancy, that is pediatric ROM, is the risk of malignancy. As you can see, in stage 3 and stage 4, it ranges. It's a very wide range. So it ranges for stage 3, it is 11 to 54, and in stage 3, it is 11 to 54, and in stage 4, it is 28 to 100. So in this case, we can go for molecular genetics in the FNA aspirates. So again, this is another modality of investigating a patient. And we have to investigate because in these cases, sometimes the child may be having low risk or a low grade of PTC as well. And sometimes these patients on follow-up, we may follow up these patients and may not require surgery in future as well. Next slide. So again, considering the histological variants, so if we have histological subtypes, and if we see that a tall cell variant of PTC, diffuse sclerosing variant of PTC, which is often common after a lymphocytic thyroiditis, and in this case, you may get a TPO antibody positive. If the histological variant is a solid trabecular variant of PTC or a poorly differentiated carcinoma, all this suggests a high risk DTC. Again, if the disease is multifocal, bilateral, extracapsular invasion, and extrathyroid extension, it suggests the high-risk disease or high-risk PTC. Next slide. Again, in genetics, so unlike in adults where RAS mutations are common, so in children, we have RET mutation, we have NTRK, which are common in children, unlike in adults where we have BRAF mutation that are more common. So the molecular classification or the molecular testing can be divided as Tier 1, Tier 2, and Tier 3. Tier 1, RAS-like oncogenes, like as you can see, RAS, DICER1, PTEN, non-B600E, BRAF mutation or fusion involvement like PAX8, PPAR, G can be assessed. In the Tier 2 intermediate risk, we have the BRAF, V600E, and Tier 3. These are the high risk for invasive behavior. So fusion involvement like RET, NTRK, LK, and BRAF mutations are common. Next slide. So which nodule needs surgery? As I have mentioned, Bethesda category 5 and 6 needs surgery, and usually in children, we do total thyroidectomy. Again, lymph node dissection. If there is it is well circumscribed, then a prophylactic lymph node dissection is again a debate. So you need same ipsilateral central lymph node can be done, but then again, lateral lymph node dissections are not indicated until and unless they are involved. Clinical suspicion of malignancy is there with a low Bethesda category. Then again, we can undergo surgery. We can go for a hemithyroidectomy if it is a localized lesion. And then intraoperative frozen section can be assessed, and accordingly, we can decide on a total thyroidectomy. If it is a low-risk PTC, then we may not do a total thyroidectomy even, because low-risk PTC may not grow, or they may be, usually studies have seen that they are not aggressive, and we may not do, but then again, it has to be discussed with the parents, and the surgeon has to decide about whether they will do the complete total thyroidectomy or not. Again, autonomous thyroid nodule, as the case has indicated, can also be treated with radiotherapy. Combined picture, we have to always see the combined picture. That is, we have to take into consideration the clinical history, physical examination, and ultrasound findings. And based on all this, a combined and integrated approach has to be done. And based on all the features, we have to decide on whether we need to put the child for surgery or not. Next slide. So again, we have this WHO classification of thyroid neoplasms. If surgery, post-surgery, we have to take into consideration as like the histopathology, whether it is a benign lesion, whether it is a low-risk neoplasm, or whether it is a malignant thyroid neoplasm. Again, based on the type of the malignancy, we can plan the follow-up of the patients. So usually, if it is a low risk also, then we will follow up the patient with ultrasound and TG levels. If the patient is a malignant and high-risk thyroid neoplasms, then we will need a iodine scintigraphy in these patients and maybe a radioiodine ablation. Next slide. So this is an integrated analysis of thyroid nodule, the low risk types that I've already mentioned. Next slide. Again, if the patient have a BRAF V600 or a red kinase fusion mutation, they are at increased risk of lymph node metastasis and distant metastasis. So when we have this genetic analysis, we know that our approach has to be aggressive. Next slide. So now how to differentiate, or what is the difference between pediatric and adult thyroid nodule? So in pediatrics, although the prevalence is less common as compared to adults regarding the thyroid nodule, but in pediatrics, the risk of malignancy is 2 to 3 times higher in a presence of a thyroid nodule as compared to an adult. So the risk of malignancy in pediatric patient is higher, that is double or triple. Again, ultrasound is a primary modality for assessing the risk in both the cases, but then size cutoff for TERAS as criteria for FNAC is not used in pediatrics, but yes, it is well defined in adults. Next slide. So to summarize, in pediatric thyroid nodules in majority of the cases is asymptomatic. We evaluate even if the size is small, that is, it is a micronodule or it is less than 1 centimeter. Ultrasound is the first modality. We check ultrasound. We do the TSH values in these patients. There is no size criteria for FNAC, so we have to take consideration of the ultrasound. And based on the ultrasound criteria, we go ahead with the FNAC. In the FNAC, if stage 3, stage 4, we do a molecular genetic analysis wherever it is possible. And based on that, we can put the patient on therapy, refer the patient for surgical intervention, whether the lymph nodes are involved, what is the type of FNAC that we have got, and accordingly, the treatment of choice for a PTC in a pediatric patient is total thyroidectomy.
Thank you very much. Can you hear me?
Yes, thank you.
Thank you very much. So it is a very
Mohan, you're lost again. Any questions? Any questions in the chat box?
Not yet, sir.
We'll just wait for the questions, Ganesh.
Yeah.
And we'll also ask them to the audience. If the audience is hearing, probably they can just post the questions in the chat box.
I request all the people who are hearing, if they have any questions, please put them in the chat box.
Yeah, some questions they have received directly. I'll read them out. A question to Ganesh sir. Can you hear me?
Yeah.
Yeah, Ganesh sir, the question question was regarding how to give therapy in case of multiple pituitary hormone deficit in a young child. So there is a different topic which they have given. A young child comes with short stature. So how will we go ahead with this, in particularly with thyroid? Because they will have a thyroid nodule. This question has come from Mumbai, one endocrinologist.
Yeah, multiple pituitary hormone deficiencies, whatever the deficient hormones to be replaced. In children, the most important hormones to be supplemented are thyroxine, the hydrocortisone, as well as the growth hormone. These are the three major hormones which are to be supplemented. So thyroxine, we have to titrate or monitor with the FT4 levels, and the FT4 to be kept between in the upper range of normal, that is in the mid range, we can say. 1.2 to 1.6 in that range you have to maintain. The FT4 has to be maintained in that range when we are titrating the dosage. And hydrocortisone, it's as per the body surface area, we have to start with the 10 to 12 milligram per square meter, and then as per the symptoms and as per the growth, we have to adjust the dosage. The growth hormone, all of us know the growth hormone, how to start and how to monitor. It will be like any other growth hormone deficiency, and as per the IGF-1 level, as well as the height, growth velocity, we have to adjust the growth hormone levels. This will be how we'll be treating and monitoring panhypopituitarism in children. Mohan, are you there? Any other question? Mohan again lost. Yeah.
Okay, because there is some party happening here, because the network is going and coming. There is a DJ party, somebody is hosting. So I am having issue here.
No
so
issue.
Can you hear me? Can you hear me?
Any other question, Mohan?
Yeah, one more question is there to you, sir. So regarding a person presents at 3 years of age, whether it is there is a question mark, there is a late onset of congenital hypothyroidism. There is a query from a person whether lifelong is required or because how are the predictors of lifelong or long-term treatment requirement in a juvenile hypothyroidism?
Yeah, so the juvenile hypothyroidism, we have to find out the cause. That is the most important thing. So if the child is having goiter, if the child is having family history of thyroid dysfunction and the autoantibody level positive, then very likely that the child will require lifelong thyroxine replacement therapy. And even dysharmonogenesis also can present in childhood. So in that, if there will be a goiter, and most of the times there will be a goiter, and we can ask for perchlorate discharge test also to find out or to confirm the cause of hypothyroidism. Or as I showed in one of my case, it can be ectopic thyroid also. Ectopic thyroid can present during childhood or even adolescence also, they can present. So in them also it will be lifelong. So most of the times the juvenile hypothyroidism, the treatment will be lifelong only. So the only subclinical hypothyroidism, transient hypothyroidism, if someone starts treatment, probably in them we can stop. And congenital hypothyroidism, definitely we have to find out the cause again. So with the help of technetium scan of thyroid, ultrasound of thyroid and thyroglobulin levels, we can find out the cause of congenital hypothyroidism. And depending on the cause, and if the requirement is very, very less, that the guidelines say if the requirement is less than 2 microgram per kg per day, then we can stop and see at the age of 3 years. So then we have to repeat it within a month to confirm that the patient is not going into hypothyroidism, because the stature will be affected if we stop in a needy child.
Okay, sir. Okay.
Any other question, Mohan, to me or Abba?
Let me ask technical team also to please check whether any questions are there.
Absolutely. There is one I can see it is Abamoni. So genetic testing, whether to be done only in Bethesda 3 or even other.
Yes, Bethesda 3 and Bethesda 4, we have to do a molecular genetics wherever the facilities are available. Even in Bethesda 5 also, if there is some like a discrepancy, then yes, you can do a molecular testing. Bethesda 6, we already know that it is a malignant case, and there is a high, the risk of malignancy is very high. That is 98 to 100% in pediatric cases if you get a Bethesda 6 slides or Bethesda 6 reading. So yes, definitely that we have to put the patient on surgery or refer the patient for surgery. So 3 and 4, yes. 5, again, if you refer the patient for surgery, that is okay. But then if you still have some controversy, one report is showing category category 5, and one slide is showing category 3. If there is some discrepancy, you can definitely go for a molecular genetic analysis.
Yeah, Abamani, there is a question. Can you hear me?
Yes, sir.
There are questions regarding pediatric eye disease, Graves orbitopathy. Anything
Yes.
particular you should do in that case?
Pediatric eye disease, there is no particular. We have patients on the pediatric Graves disease where the treatment is similar to adults. We give methylprednisolone as a like methylprednisolone pulse therapy if the disease is active. If it is inactive, then it again depends. I do not know what is the question regarding that.
Regarding using Graves disease in adults and Graves disease in pediatrics, anything difference is there? That's the question. Is it same management? Yeah.
Yes. So in pediatrics, we give the doses of metimazole maybe 0.15 to 0.5 milligram per kg body weight. When we do it by milligram per kg body weight, usually the requirement of doses is higher in children as compared to adults of anti-thyroid medications. So that is one difference between adult and pediatrics. Number two, again, the Graves disease, they will usually, if it is a pediatric onset, usually they last very long. So we may have to consider treatment for long duration, maybe 5 years, even up to 7, 8 years also. Anti-thyroid medications has been continued. Again, the use of radioactive iodine, radioactive ablation in pediatric Graves. So in adults, maybe we can decide on radioactive iodine after 2 years or 3 years of anti-thyroid medication as a definitive treatment. But this is not a treatment of choice in children. Because in children, again, there is a risk of second malignancy, second primary malignancies, and again, the risk of radiation, and also radioiodine may cause infertility, especially in males. So again, there are a lot of risks. So in children, we would always like to continue anti-thyroid medications for a long duration of time.
Selenium, can it be given? Selenium also, can it be given in pediatric Graves disease? Is it any role in adult thing? That is also one more thing which, can you hear me?
Yeah. Selenium can be given. Yes. Selenium can also be given.
Okay, fine. So I think that is the questions which I got from my internal messaging. Sorry that internet, I cannot open my video because so much of audio clashing here. So anything else is there? I think one question is there in chat box. Can you hear it? See that? Can we do FNAC in patients who have toxicosis? I think both of you can answer this question. Why should we go with nuclear scan? That means the purpose of doing the cold nodule or not? That's what I think maybe the indirect question. Can you read the question there? Question is posted by the technical team there. Can we do FNAC in patients who have toxicosis? That means, is it an active hyperthyroidism? That is what I think. Thyrotoxicosis, I think. Why should we not go with nuclear scan? Something like that. Okay. Can you understand that question?
Yeah. Ganesh, sir?
Yeah. I think when the patient is presenting with toxicosis and if the patient is having diffuse goiter, definitely we can ask for a technetium scan. And if the technetium scan is showing a cold nodule, then we can go ahead with the FNAC of the cold nodule. If the patient is having only one single nodule, then again we can go for a technetium scan. If showing a cold nodule, then FNAC. Yeah, that would be fine. So, Abba, you have any different answer?
It is same for pediatric as that would be the question. I think that is that adult and pediatric same? That is what may be asked here. I think, I don't know. Maybe that person can clarify. Abba, anything to add?
Yes, the idea is like what the flow chart says. First, do an ultrasound. If there is a thyroid nodule, and if it has a toxic features, like the TSH is suppressed, we should go for a scintigraphy. Yes, that is the idea. But then in most of the places, like in our hospital, we don't have scintigraphy available in our hospital. So if we have any suspicious nodule, then we can go for a FNAC even if the TSH is suppressed and we have a suspicious lesion. As Dr. Ganesh sir has already mentioned, so if it is a hot nodule, then we can directly decide on that, yes, it is autonomous thyroid nodule. Even autonomous thyroid nodule can also are at risk of malignancy. Even they can coexist with malignancy.
Yeah, fine. Well, there's one more question. I think it is related to me. The primary hypothyroidism by the patient I have showed actually. So whether it is a thyrotroph adenoma or thyrotroph hyperplasia. Yes, to be correct, it is a thyrotroph hyperplasia, which will on its own it will regress. but it is named as thyrotrophic adenoma in the literature. So it's not TSH secreting adenoma, it is thyrotrophic adenoma. We can call it as thyrotrophic hyperplasia also. I agree. I think there are no further questions.
Yeah. There are no more questions. Dr. Arun Menon, sir, anything from you to be added, sir? If you are there in the audio is clear. Can you hear me? Okay, so we'll wait for Arun Menon, sir. Meanwhile, let us, I think it was a very interesting and very good discussion. Thank you, both panelists and your trainees. I really commend that you have done a great job in your students. And thank you for presenting very good cases for this webinar. So I hope you can all present again, and next time we'll have more episodes like this. I think there is a request to keep on doing activities like this. That is kudos to you for taking the energetic lead. So let me go to the last part of the discussion. Let me welcome Dr. V. Srinagesh, who is a senior endocrinologist and our brain behind this task force. Over to you, sir. Maybe just vote of thanks from you, sir.
Yeah. Thank you, Mohan. At the outset, I was very happy to see the program today that a Pediatric Endocrine Task Force program has taken off. And the entire credit for this goes to the team of Endocrine Society and ITS. At the outset, I'd like to thank our President Narendra Kotwal, sir, who has taken time out of his busy schedule to be a part of this meeting and address and give us a few introductory remarks. We are also deeply grateful to Krishna Seshadri, sir, who's been the guiding force behind this program and has given us a great amount of latitude in formulating this program. So also thanks always to Arun Menon sir and Premila Kalra ma'am, who have helped us a lot in doing a joint program of Endocrine Society and ITS. And in future, we hope there will be many more joint programs because many of us are members of both societies and this is a very synergistic combination. I would also like to thank my dear friend H.K. Ganesh, who is one of the principal movers and shakers behind this pediatric task force. He was presented such excellent cases today, as also thanks to Abhamani, who has given us a very lucid and interesting approach to a pediatric thyroid nodule, including the diagnostic algorithms and the genetic underpinnings. Thanks to our enthusiastic postgraduates, Dr. Satyavamshi and Dr. Annu Tiwari, without whom this discussion would be very incomplete. I'd also like to thank the team of the technical team of this program, who's done a lot of hard work in ensuring that this program has reached out to a lot of people. And last and definitely not the least, the power behind this entire task force, which is Mohan Shenoy. Without Mohan, I don't think it is possible for anybody to do any activity in Endocrine Society for the last 4 or 5 years. He's been the complete backbone of every single activity of the Endocrine Society. Everybody has 24 hours in a day, Mohan has 48. And we only hope we'll have many more programs and Mohan ends up making 72 hours in his day for all these Endocrine Society activities.
Thank you, sir. Thank you,
once again, and it is very happy to finally get our Pediatric Endocrine Task Force off the ground. And we hope we'll have a lot more programs in the future because we need to do much more work in endocrine, pediatric endocrine sphere. Everybody is asking for this, and we hope this will be a very good beginning. Thank you, one and all.
Thank you. Technical team, can you just put the last slide for the tomorrow's program?
Sure, sir.
Thank you. So you can see tomorrow's program is here on the screen. Tomorrow we are starting at 11 a.m. Till 2 p.m. So we start with puberty. We then go to pregnancy. Women and thyroid is the theme. Then we go to osteoporosis. Next slide, please. Then we go to cognition also. And the last, we have a panel discussion on thyroid nodules in pregnancy. And we also have a quiz, which is led by Dr. Abhamani Baro again. She is going to give us prizes also for good performance there, chaired by Dr. Vinny Pillai. This program is very good, and I wish all of you can join tomorrow. Link is same, audience link is same. So it's available on YouTube also. So definitely it's a good program worth listening and worth joining. So thank you all for joining today. So it's a pleasure for me to have been here with you. So thank you, and please join in again for our programs in future. Thank you, dear panelists. Thank you, everybody. Thank you, technical team. Thank you, audience also. Thank you very much.
Thank you.
It's me signing off. Jai Hind.